I'm calling to order this hearing. This is a public hearing of the Committee of the Whole of the Council of the District of Columbia. It's actually a joint hearing, the Committee of the Whole and the Committee on Health, chaired by Councilmember Christina Henderson. The subject of today's hearing is consideration of two bills. Bill 25-570, entitled the Cardiac Planning and Response CPR Amendment Act of 2023, which was introduced by Councilmembers McDuffie, Allen, Lewis, George, Parker, Pinto, Nadeau, Bonds, Robert White, and Fruman on November 9th of last year. And the second bill is Bill 25-571, entitled Seizure Safe Schools Amendment Act of 2023, which was introduced by Councilmembers Allen, Nadeau, Fruman, Trayon White, Robert White, Pinto, Lewis, George, Bonds, and myself on November 13th of last year. The stated purpose of Bill 25-570, the Cardiac Planning and Response Bill, is to require each school in the district to develop a cardiac emergency response plan, to identify the appropriate school personnel to respond to a cardiac arrest or similar life-threatening emergency on school grounds, and for each middle and high school to develop the same for athletic practices or events. The cardiac emergency response plan must include who will respond in the case of an emergency, how they will respond, and how staff will be trained to that effect. The legislation also requires school officials to integrate best practices for engaging with local emergency services and AED placement into the plans. The stated purpose of Bill 25-571, the Seizure Safe Schools Amendment Act, is to require each student diagnosed with a seizure disorder to have an individualized health plan developed by their school that details pertinent medical and personal information for their treatment and care. It also requires schools to have at least 2 employees trained to respond appropriately to seizures and to administer medication. There are several council members who are participating virtually, including the co-chair of this hearing, Councilmember Henderson, and they'll probably in their opening statements give more details with regard to estimates nationally, maybe even locally, with regard to seizures and cardiac emergencies. The hearing record for this hearing will be open for 2 weeks. It will close at 5 p.m. on Wednesday, July 24th, 2024. Anyone who's not submitted a statement or wishes to can do so through the council's hearing management system, which is available on the council's website, www.dccouncil.gov, or more specifically, dccouncil.gov/hearings. So statements can be submitted that way. With that, let me turn to colleagues. First, the co-chair of this hearing, Councilmember Christina Henderson.
Thank you, Mr. Chairman, and good afternoon to everyone. I look forward to our discussion today on Bill 25-570, the Cardiac Planning and Response Amendment Act of 2023. While I recognize the importance of schools having comprehensive emergency response plans, I am interested in examining the necessity of legislating some of these very specific protocols that are in the bill. Additionally, we already have some laws in place as it pertains to AEDs and CPR training. And I'll be asking some of the executive witnesses today about the implementations of those existing laws on the books. And so I appreciate everyone for being here on that today. I also look forward to a discussion on Bill 25-571, the Seizure Safe Schools Amendment Act of 2023. Although seizure disorders are a rare health condition, they are very serious for some children. And we want to ensure that our schools have the resources that they need to respond quickly and adeptly to a seizure-related emergency. In part, that's why last October, the council did a comprehensive approach by passing Bill 25-226, the Access to Emergency Medications Amendment Act of 2023, which was fully funded in the FY25 budget. That bill requires DC Health to create an undesignated emergency medications action plan that authorizes public schools to possess and administer undesignated emergency medications determined by the Department of Health. That bill also requires the schools to have at least 2 trained staff to administer undesignated emergency medications and also requires DC Health to stock these medications at schools. Although the bill does not specifically require seizure trainings and medication, the bill does give DC Health the regulatory authority to add or remove medications by rulemaking. And DC Health did tell the committee during the bill development that seizure medication should be included in their initial rulemaking. Given that the access to emergency medications bill will start to be implemented this October, I'm going to use my questions to ask DC Health how the planning for that is going, and whether or not this additional piece of legislation is considered to be duplicative of the work that they're already doing. With that, I do appreciate all of the folks for signing up to testify today, and I look forward to the conversation. Thank you, Mr. Chairman.
Thank you, Councilmember. I'm not sure what order other members arrived, so I'm going to go with Councilmember Allen, then McDuffie, and then White, unless you correct me. So, Councilmember Allen, do you have a statement?
I do, and as long as nobody corrects you, I'll just jump right in. I want to thank you, Mr. Chairman, and Chair Henderson for holding today's joint hearing. While I think we're all familiar with epilepsy as a disease or disorder, I think what we're all less familiar with is actually how epilepsy can affect a young person in their daily life. In the district, there's approximately 800 children and teens living with epilepsies. A CDC study showed that when compared with students with other health concerns, students aged 6 to 17 years old with epilepsy were more likely to miss 11 or more days of school in that past year. The study also noted that students with epilepsy were more likely to experience difficulties in school, use special education services, and have limitations when it comes to playing sports or participating in other after-school activities compared to students with other medical conditions. I think that everyone on this council agrees that students need to be in school. In order to do that, we need to make sure that the schools and the students themselves have the resources and the support that they need to succeed. I've said this before at the hearing on legislation addressing chronic absenteeism and truancy, and my thinking is the same here too. With respect to students with epilepsies, we need to ensure that their learning environments are safe and that they're supportive and that they have access to the necessary care and medication. Bill 25571, our Seizure Safe Schools Amendment Act of 2024, I think will go a long way to ensure that students with epilepsies are guaranteed a safe and supportive learning environment at school. I won't go through the provisions of the bill right now in detail, but big picture, this bill is going to incorporate tools, training, and resources to prepare our educators for any seizures that may occur in their classrooms or on school campuses. With that, and before I conclude, I do want to acknowledge and give my thanks to the public witnesses who are testifying today, particularly the students and parents that advocated and worked with both my office and Councilor Robert White's office to get us here today. A special thanks goes to Molly Ellis and Oliver Teneo for your impassioned advocacy. I also want to thank the Epilepsy Foundation for their advocacy as well as their partnership. And I also want to thank my own Ward 6 State Board of Education representative, Brandon Best, who advocated for this policy at the state board and led the state board to a resolution supporting and calling on the council to pass this legislation. Again, my thanks to everybody who's testifying today, and thank you, Mr. Chairman and Chair Henderson, for convening today.
Thank you, Councilmember. Councilmember McDuffie.
Thank you, Chairman Mendelson, as well as Chair Henderson, both for holding this joint public hearing that includes one of my bills that I introduced along with several colleagues, which is the Cardiac Planning and Response Amendment Act of 2023. According to the Centers for Disease Control and Prevention, roughly 2,000 young, seemingly healthy people under the age of 25 in the United States die each year of sudden cardiac arrest. And according to the American Heart Association, 40% of youth cardiac arrests are sports related. So I introduced this bill alongside 8 of my colleagues because all students, and student athletes in particular, deserve to receive high quality and immediate life-saving care in response to cardiac arrest. And as a father of 2 student athletes, this legislation takes on special importance to me. This bill expands upon work that I led as chairperson of the Committee on Judiciary. In 2015, I introduced the Office of Unified Communications Training, CPR, and Modernization Amendment Act of 2015. Among other things, this bill required the Office of Unified Communications and Fire and Emergency Medical Services to conduct a district-wide CPR training program for district students, employees, and residents. The council expanded upon and incorporated this bill in the fiscal year 2017 Budget Support Act of 2016. This law additionally mandated the placement of an automated external defibrillator, or AED, in every school that would be readily available for every athletic event. It required AED use and CPR training for every athletic coach, trainer, and school nurse, and it mandated public and public charter high schools to provide CPR and AED training. This law also required schools to establish procedures for responding to cardiac arrest. The CPR Amendment Act of 2023 would enhance existing law by requiring schools to develop an evidence-based cardiac emergency response plan to respond to incidents involving an individual experiencing cardiac arrest or a similar life-threatening emergency while on school grounds. It would also require middle and high schools with an athletic department or organized athletic program to develop a cardiac emergency response plan to respond to incidents involving an individual experiencing cardiac arrest or a similar life-threatening emergency while attending or participating in an athletic practice or event while on school grounds. And I want to thank the American Heart Association and 2023 Miss District of Columbia, Jude Bambone, for working with me and my team on this bill. Thank you to all the witnesses who signed up to testify today, and I look forward to hearing your testimony and your thoughts on the bill.
Thank you, Councilmember McDuffie. Councilmember Robert White.
Thank you, Mr. Chairman, and thank you to Councilmember Henderson for fitting this hearing in before recess. Ideas for legislation come to the council in a variety of ways, from national organizations, businesses, bills passed by other states, or as a reaction to an event. But often, the most impactful legislation comes from the people who would be impacted most by its passage. That's exactly how the Seizure Safe Schools Amendment Act of 2023 came to me and Councilmember Allen. One of our residents, Oliver, a student at a DC school, began advocating for legislation to ensure that DC schools are a safe learning environment for kids who experience seizures. Oliver told us that sometimes teachers and classmates might not notice or understand that a student is having a seizure. And when they do notice, without a little training, they won't inherently know what to do. This means that proper first aid and medications could be delayed. Last November, Oliver told me and Councilmember Allen a powerful story about attending a conference hosted by the Epilepsy Foundation. He realized that while he was there, surrounded by other kids and adults who were trained, who knew what to do when someone had a seizure, he felt safe. Oliver felt safe. When you feel safe, you can relax and focus on what's in front of you instead of worrying about what might or might not happen. Through this legislation, Oliver wants any DC student who has epilepsy or who experiences seizures to feel safe when they're at school so they can focus on learning instead of what could happen if they have a seizure. The bill would require at least 2 staff members at all schools in DC be trained in seizure recognition and administering emergency seizure medication, and ensure students with epilepsy and other seizure disorders have seizure action plans identified in their school files. It would require schools to provide training every 2 years to staff on recognizing signs and symptoms of seizures and the appropriate steps for seizure first aid, and it would require age-appropriate epilepsy and seizure awareness education for all students. If passed, this legislation means that students who have epilepsy or experience seizures will get help faster. It means that their peers and teachers will have a greater understanding of their experiences, and it means that students will feel safer at school. I want to thank the many families who have taken time to advocate for this measure, including the Coppola and Ellis families, State Board of Education Representative Brandon Bess for introducing a State Board of Education resolution supporting this bill's intent, and Councilmember Allen for working together with me to introduce this measure. Thank you again to the witnesses for being here, and I look forward to hearing your testimonies.
Thank you, Councilmember. So I'm going to call witnesses in the order on the witness list. That makes sense. But I'm going to keep calling until there are 4 seats filled, or I get halfway through the list. Robert Henderson, Ward 8 State Board of Education member. Did I say Ward 8, Ward 5? Molly Ellis. Ava Ellis, Aaron Ellis, Oliver Teneo Coppola, Stuart Burlow, Caitlin Arbuckle, Ariel White, Adam Prinzo, Delara Somerville, um, School Board Member Henderson, you're first. And good afternoon.
Good afternoon, Chairman Mendelson. Thank you for convening this hearing along with Councilmember Henderson. I want to thank Council Members Allen and White for introducing the Seizure Safe Schools Amendment Act of 2023. I also want to acknowledge SBOE Representative Brandon Best for helping to bring this issue to the attention of the State Board and working with Councilmember Allen and Councilmember White on this bill. I am the Ward 5 member of the State Board of Education. These views are my own and do not represent the views of the board as a whole. I can say, though, as you know, that the State Board unanimously passed State Resolution 23-6, recommending that the council pass legislation on seizure safe schools that incorporates 5 key components recommended by the Epilepsy Foundation. And I do believe that this bill does that. On May 17th, 2023, the State Board of Education heard moving and persuasive testimony from Oliver Teneo Coppola and Molly Ellis, both of whom you will hear from today and who have been mentioned already, about the need for training in seizure recognition and response in our schools. It so happened that on the same panel of witnesses was an educator who had come to testify about a different issue, but she testified that she had had a student experience their first seizure in her classroom that year, and shared that she had received no prior training on how to respond and very much wished that she had. On the basis of this testimony, Representative Best worked with witnesses and experts to craft the resolution that I mentioned previously. I'm conscious of the need to resist the temptation to require training before the school year for all the many things that we want teachers to do and to be able to do, but this is a relatively light lift with potentially life-saving impact and is absolutely necessary. Similarly, I support the Cardiac Planning and Response Amendment Act of 2023. I hope the council will pass both these bills and that they will be faithfully implemented by the appropriate parties. I heard Councilmember Henderson raise the question of whether this legislation is duplicative of previous legislation. I would want to know if the other legislation requires the training that this bill would in terms of seizure recognition, because I think that's a really important aspect of this bill. Thank you very much.
Thank you, Mr. Henderson. Molly Ellis.
Hi, my name is Molly Ellis. Thank you so much for hearing my testimony and the testimonies of others who support the Seizure Safe Schools Amendment Act of 2023. My daughter Ava is an 8-year-old DCPS student who is living with epilepsy. Ava's seizures are triggered by migraines and are preventable when her migraines are managed. In March of 2023, I became a seizure first aid instructor through the Epilepsy Foundation. March of 2023 was also the last time Ava has had a seizure. She's been seizure-free since March 31st, 2023. Over the last year and a half, I've been able to train nearly 40 of the teachers and staff members at her school to become seizure first aid trained. The training includes what to do in case of a seizure, but also teaches the importance of responding to an individual's seizure triggers and the mental health of the people with epilepsy. There is not a teacher at her school who doesn't know who she is, specific details of her seizure action plan, what her seizures look like, and what triggers them. They all know the side effects of her medications and how the life-saving medications she takes every day impact her brain and her ability to learn. This year, she went to the nurse 21 times with migraines. 21 times the staff and sometimes the nurse or nurse tech believed her, treated her, and followed her action plans. She made it the entire school year and then some with no seizures. The last 2 years, I've also been able to go into her classroom and teach her classmates about epilepsy in an age-appropriate way. Using picture books and child-friendly vocabulary, I've been able to partner with her teachers to foster empathy and to help Ava's classmates understand some of what she goes through because of epilepsy. Ava's story is a success story. She is proof that seizure action plans combined with seizure first aid and education about seizures and epilepsy work to protect kids. Epilepsy has changed her life, and there are so many things she cannot do safely. Going to school safely should not ever be something that she is not able to do, and the passing of this bill will ensure that any school she attends in DC will be safe for her. Ava's lucky. She has teachers and a principal who allowed me to teach them how to keep her safe. They have advocated for her when visiting nurses didn't want to or couldn't help her. They have recognized the importance of preventing seizures in order to minimize the amount of time that Ava misses in school because of epilepsy. Every single kid in DC who has epilepsy or another seizure disorder deserves to be as lucky as Ava. They deserve to be safe at school and to belong to a school community that understands and empathizes with them. Please vote to pass this bill. Ava and all the other kids in DC who are impacted by seizures deserve it.
Thank you, Ms. Ellis. Ava Ellis, is she here?
She should be virtual. They said they were logged in.
I think she needs to accept. Ava Ellis, you're up. If you are speaking, you're muted, but we can see you.
Start over.
Okay. Thank you everyone for hearing my testimony today. My name is Ava. I am 8 years old and I live in Washington, D.C. I have epilepsy. We seizure kids just want to feel safe everywhere we go, at home, in public, and especially at our schools. This seizure safe school bill will help us feel safe when we go to school. Please pass this bill so we can feel safe at any school we go to and everywhere. Thank you.
Thank you, Ms. Ellis. Thank you for your testimony. Erin Ellis? Okay, then that gets us to Oliver Teneo Coppola.
Hi. Hi, my name is Oliver, and I'm a resident of Ward 6. First off, I want to say thank you to council members Charles Allen and Robert White, as well as Board of Education Representative Brandon Best for leading this initiative to help make schools in DC safer for those with seizures. If passed, DC will join 25 other states, including Maryland and Virginia, in passing seizure-safe school legislation. 1 in 26 people have epilepsy, and in DC, around 800 kids have epilepsy, and even more have seizures. The American Academy of Pediatrics has identified seizures as one of the top 3 leading medical emergencies in schools. I know that doctors, including my own, are submitting written testimony about the need for and impact of this proposed law. As a DC resident and teen living with epilepsy, I urge you to please protect our children. When I was diagnosed with epilepsy at the end of 1st grade. If my teacher had been trained, she would have recognized I'd been having absence seizures for many months before my tonic-clonic seizures started occurring. And I think that she could have helped stop that before, or stop them sooner. Today, I'm seizure-free, but I worry for the kids in DC who are not and aren't able to have their rescue medicine when they're having a seizure, and also for the teachers who don't know what to do when a kid is having a seizure. The bill includes a seizure safety aid or seizure first aid plan, which takes 30 minutes takes 30 minutes to learn, and it's super easy to administer. Those 30 minutes could be the difference between life or death. I'm also really grateful that this bill requires seizure and epilepsy awareness education for all students. When I had seizures, I faced discrimination from other kids, and many kids with other health issues face or not face, sorry, are praised for their bravery, but because of the history of misunderstanding with epilepsy, kids with seizures are discriminated against and mistreated. No kid should have a seizure and not have anyone around them know what to do, and no teacher should feel helpless not knowing what to do just because they didn't have training. Thank you.
Thank you, Mr. Coppola, and thank you for sharing your story. Stuart Perlow?
Thank you, Chairman, for holding this hearing before the break. And Councilmember McDuffie, thank you again for the leadership that you discussed in your opening statement. We appreciate the many years that you've helped to make the district a safer place for all of us. The American Heart Association strongly supports this bill, the cardiac emergency response plan legislation before you, Bill 570. This is a key part of the chain of survival to make sure that schools are as safe as possible for anybody having a cardiac arrest. Like whether that's a student, a teacher, a coach, an athlete, anybody in that school environment. Last year, when Damar Hamlin had his cardiac arrest on Monday Night Football, I think we all saw how important it is for that chain of survival to work perfectly. To have a group of people that are trained to respond, know what to do, and are able to jump into action and quite literally save a life. We all saw that happen live on national TV, and we want to make sure that that same is the case for any student athlete, or anybody else in a school environment in the district. 10 states around the country have already passed similar legislation, including our neighbors up in Maryland. And this is so critically important because the data is very clear that these cardiac emergency response plans, or CERPs as they're sometimes called, they work. Schools that have a CERP in place can see up to a 50% increase in survival versus those that don't. And this is critically important because when someone has a cardiac arrest, when their heart stops beating, oxygen isn't getting to the brain, blood isn't flowing. For every minute that goes by, the chance of survival drops 10%. So if someone collapses at a school or here at the council and nobody knows what to do, there isn't a plan to respond, and fire and EMS, let's say they take 4 minutes to get there, your chance of survival's already dropped to 60%. So it is critical that schools are prepared. We know that there are about 1,000 cardiac arrests in the district every year. They happen most frequently, unfortunately, in wards 8, 7, 6, and 5. And we know, and according to fire and EMS data, there were about 33 cardiac arrests last year that happened here in the district among kids under age 18. So as Councilmember McDuffie mentioned, he and this council have been leaders in the country in ensuring every student is trained in CPR, that so many others in the school environment are trained, and that schools have AEDs. And Councilmember Allen has been a terrific leader in increasing and strengthening our chain of survival, ensuring that OUC call takers are trained to teach 911 over the phone when someone calls 911. The district has done so much to make the district a healthier place for all residents, visitors, anyone who might experience a cardiac arrest. And now this is another key component in that chain of survival. So we would ask the council to follow the lead of our neighbors in Maryland and the 10 other states that have passed these laws, with many more to come, I'm sure, and making sure that all schools are prepared by having a cardiac emergency response plan. Thank you.
Thank you, Mr. Burlow. Caitlin Arbuckle?
Thank you for hearing my testimony. I wanted to share my firsthand experience with the importance of seizure safe training in schools and advocate for the passage of the Seizure Safe Schools Amendment. As a 4th grade teacher in the District of Columbia, I had the privilege of receiving seizure safe training at Brent Elementary from Molly Ellis during the 2022-2023 school year. Little did I know how invaluable that training would become just a year later. This past spring, a student in my classroom had a seizure. It was a moment of panic and fear for both the student and myself. As the adult in charge, I felt the weight of the responsibility on my shoulders. However, thanks to the training I had received, I was able to remain calm and recall the necessary steps to ensure the safety of the student. I got the child in a safe position and sought help as swiftly as possible. While it was a frightening experience, I am grateful that the child recovered well. Reflecting on that day, I realized the immense impact that seizure safe training had on my ability to respond effectively in a crisis. The training not only equipped me with the knowledge and skills to assist a student in need, but also provided me with the confidence to handle such situations with clarity. I am now more assured of my capability to help anyone, student or otherwise, experiencing a seizure. It is clear to me that all school staff should receive seizure safe training to ensure the safety and well-being of our students. The Seizure Safe Schools Amendment is a critical step in implementing policies and procedures that will empower educators to respond appropriately to seizures in schools. By supporting this amendment, we can create a safer and more inclusive learning environment for all students. I urge the committee to prioritize the passage of the Seizure Safe Schools Amendment and make seizure safe training a standard practice in schools across DC. Together, we can ensure that every student receives the care and support they deserve. Thank you for your time and for hearing my testimony.
Thank you, Ms. Arbuckle. Ariel White.
Hello. My name is Ariel White. Thank you for the opportunity to speak with you today in support of the Cardiac Planning and Response Amendment Act of 2023. I'm a pediatrician, adult internist, and adolescent medicine specialist. I'm speaking with you today as a representative of the DC chapter of the American Academy of Pediatrics, a local chapter of a national organization representing 64,000 pediatricians. The DC chapter represents over 400 members, including pediatricians, advanced practice clinicians, and medical trainees from all 8 wards. In addition to my medical credentials, I'm a native Washingtonian who has personally experienced the importance of having clear protocols in the event of a cardiac emergency. In 2022, my partner was diagnosed with ARVC, a condition that causes dangerous cardiac rhythms, and as a result, he has required 3 life-saving defibrillator shocks. As a result of his diagnosis, there is a 50% chance that our children are genetically at risk for a cardiac arrest. Since his diagnosis, I have met many families who have lost loved ones, often children, to sudden cardiac arrest, a medical emergency where the heart abruptly stops bleeding. While significant research is needed to prevent these events, having a clear response protocol could prevent catastrophic outcomes. About 210,000 Americans will die suddenly and unexpectedly per year due to a sudden cardiac arrest. About 2,000 will be under the age of 25. 1 in every 200,000 healthy high school athletes in the U.S. dies annually from a sudden cardiac event. And in fact, long QT syndrome, a condition that causes sudden cardiac arrest, is 3 times more common than childhood leukemia. Immediate CPR and AED use can triple a victim's chances of surviving. In my clinical work, I've seen the importance of a quick emergency intervention. As a first day as a 4th-year medical student in the pediatric ICU, I followed 2 teenage boys who had suffered cardiac events and were on life support. Both were previously healthy with no known risk factors for cardiac disease. One patient received immediate CPR at the scene and survived the incident without brain damage. However, the other patient did not get immediate treatment and passed away a week after his arrest. The discordant outcome of these cases highlights the importance for immediate treatment with CPR and an AED. Furthermore, while CPR and AED awareness and training is important, this bill specifically calls for the development of an emergency response protocol for schools to follow in the event of a cardiac emergency. Developing a formalized protocol for responding to these events is vitally important, as it will ensure that the emergency care is delivered efficiently and effectively. Having participated in cardiac arrest both in and out of the hospital, I know from experience that during an emergency, emotions are very high. It's easy for the environment to become disorganized and confusing, which can delay care. I recently responded to a cardiac emergency in the field where there were so many bystanders experiencing panic, it was hard to determine if the emergency response system had even been activated. Having a protocol in place helps ensure that treatment is delivered as quickly as possible in a stressful, often chaotic environment. An organized immediate response to a cardiac arrest can save a child's life. Previous legislation has recognized the need for CPR and AED training for adult staff working in schools, but this bill will improve upon prior legislation to ensure that emergency care is provided smoothly and calmly, thus increasing the likelihood of a positive outcome and making DC schools safer for all students and staff. Thank you very much.
Thank you, Ms. White. Adam Prinzo.
Chairman Mendelson, Chairperson Henderson, and members of the committee, thank you for the opportunity to provide testimony before this committee. I am Adam Prinzo, Advisory Neighborhood Commissioner for 3CO2, representing Woodley Park. I am testifying today on behalf of myself as well as on behalf of ANC 3C, authorized by a resolution submitted to the record in support of this bill. I am here today to express my support for Bill 25570, the Cardiac Planning and Response Act Amendment Act of 2023. Cardiac arrest is a serious public health issue that requires immediate and effective response. The survival rate for out-of-hospital cardiac arrest remains alarmingly low, and quick intervention is crucial to saving lives. The bill aims to enhance preparedness and response to cardiac emergencies, and I believe it is a crucial step towards improving public health outcomes in our community and in our schools. Raising public awareness about the signs of cardiac issues and the importance of early intervention is critical. This bill would require schools to develop an evidence-based cardiac emergency response plan to respond to incidents involving an individual experiencing cardiac arrest or other similar life-threatening injuries, while on school grounds or participating in an athletic event or practice. I'd also like to note in our community, CPR and other life-saving emergency trainings such as Narcan have been offered by the Woodley Park Main Streets program for all district residents to partake in during their monthly markets. And I'd also personally like to commend the advocacy of my neighbor, Jude Mabonnet, for her advocacy on cardiac health throughout the district. This past year, Jude served as Miss District of Columbia 2023, and during her year of service to the district, she raised awareness in all 8 wards on the importance of cardiac health. She did this bill with Councilmember McDuffie, and she also came before our ANC in December of last year to talk about this bill. She is a 6-time heart attack survivor, and we are grateful she used her unfortunate experiences to better the lives of others throughout the district. I urge council to pass this critical piece of legislation to protect the health and well-being of our students, and I thank you for the opportunity to testify today.
Thank you, Commissioner. Delara Somerville.
Chairman Mendelson and members of the committee. My name is Dela Somerville, full name Delara. I'm a resident of Ward 6. Around 2.5 years ago, on a dark October morning, I left my house with my husband and 2 school-aged children still sleeping at home, and went for a run in my neighborhood, Capitol Hill. It was Wednesday, our Capitol Hill Loops Day, when my running group ran around the Capitol in circles early in the morning. I do not remember that day and the following 2 days, but what I understand from others told me, at some point during the run, I got separated from everyone else and fell on the ground right outside the Capitol. Congresswoman Vicky Hartzler, who was also on her morning run, ran by me and then came back, realizing something was not right. She called for help. At that point, I was not breathing. I did not have a pulse. Capitol Hill Police K-9 Unit Tech Kevin Grebeck performed cardiopulmonary resuscitation, CPR. Officer Michaela Brower administered an automated external defibrillator, AED, to restart my heart. Bystanders were holding flashlights. Surgeon Corey Rogers was on scene coordinating. He held on to my glasses, kept them for weeks to make sure I get them back. DC Fire and EMS arrived and took me to the hospital. Everything happened so quickly, nobody knew who I was. But there was a whole community of people who knew what to do and helped just one person, me. Like in my case, most cardiac arrests happen outside the hospital. Only about 1 in 10 people survive. I was lucky, I survived. My cardiac arrest happened in a place with people trained in CPR. They had AEDs nearby and accessible. They were able to communicate with each other and call for help. I was very fortunate to receive such prompt care by people trained to act quickly and help save lives. Damar Hamlin also survived thanks to similar planning in the NFL. If it happened to me, if it happened to Damar, it could really happen to anyone. But what if a cardiac arrest happens in a place where there is no plan, where people aren't trained to respond, where people don't know what to do? The same planning and basic training should be in place at every school in the district and at the sports facilities to make sure every student, athlete, teacher, and others in schools in Washington, D.C. are safe and protected. I ask the council to support and pass the CPR Act. In a cardiac arrest, every minute counts. The CPR Act will make sure all district schools are ready by having them develop cardiac emergency response plans, which lay out the steps that schools need to take to be ready for cardiac emergencies. Everyone at a school or a school sports event should have the same chance for survival as I did on Capitol Hill. Thank you for listening to my story. I ask you to support and pass the CPR Act so all schools can be ready to respond to a cardiac arrest and save lives.
Thank you, Ms. Somerville. Thank you for sharing your story. Some of these stories may not be easy to share, but thank you. I just have a couple of questions and I'll turn to colleagues. Ms. Ellis and Mr. Coppola. So you've heard some testimony that legislation passed by the council last fall covers this issue. Have you looked at the legislation? Do you have a view?
I have. The big thing about what we're asking for is that people know what seizures are and how to respond to them before it's an emergency. Ava's a great case in point. Her school team knows her triggers, knows what to look for to prevent seizures. And while I don't disagree that emergency medication absolutely should be in schools for somebody who was not previously known to have seizures, there are kids living in DC with epilepsy, and those kids deserve to be protected too. Their seizures don't have to be emergencies. Their epilepsy doesn't have to result in them missing tons of school or carrying the stigma that comes with epilepsy. So while I don't disagree that emergency medication should be, or the seizure rescue medication should be included at schools, this bill is taking it farther to protect kids in DC who have epilepsy or other seizure disorders.
Taking it farther by, this bill takes it farther by,
by providing training for what teachers need to do, because while it's great that there are two people who are trained to administer the medication, seizures don't always end up as a medical emergency. Sometimes they're resolved within minutes or hours and kids go back to school. Teachers need to know what to do even if it's not an emergency. It also helps train the school community to be more empathetic and understanding of what kids with epilepsy go through. And so it just fosters the sense of community that we really want to see in our DC schools.
Thank you. And Commissioner Prinzo, you indicated that your commission has adopted a resolution.
Yes.
Yeah, I don't think we have it.
Okay, I can resend it.
Do I have it? No. And a copy of your statement as well?
Yes, we'll send that along as well too.
Thank you. Councilmember Co-Chair Henderson?
Thank you, Mr. Chairman. Is Ms. Arbuckle still on? I see your box, but
Yes, I'm here.
Hi, how are you? Okay,
Yeah.
I'm very interested to chat with you a little bit because you're a teacher in schools. And every time we talk about CPR training or administer of medication training, these are all things that folks want every teacher in the building to do, but it is also quite time intensive as well. You said in your testimony that you were trained in terms of recognizing on seizures. I'm curious, are you one of the individuals who has gone through administration of medication training at your school?
No, I have not done the administration of medication training.
Okay. Are there other things that you wish you had been trained on in terms of understanding things? So seizures is one, but there's a large percentage of young people in the district who have asthma, for instance. There are a large percentage of students in the district who have hypoglycemia. Many of them might have asthma action plans on file or diabetes action plans on file. A lot of them don't actually have those on file. Is that something that there's a desire from fellow teachers to also be trained on? I'm trying to understand, if not just seizures, should it be a wide range of understanding of basic, I guess, things to look out for commonly known emergencies that might arise in your classroom?
I mean, ideally, yes, I would love to be trained in all of those things. I think you never know when it's going to happen in your classroom, and when you're the only adult and there's some kind of medical emergency, it's scary, and it can be hard to like know what to do. I think there are like lots of like case by case scenarios. Like I know a student who has an inhaler, or I know a student who has an EpiPen. I think what was a little bit different about the seizure in my classroom is I have never had that, where I feel like I've had other students with other medical needs in my classroom, but I've never had a student who experienced seizures. So I think that in particular, I was really grateful to have had that training, because otherwise I have never experienced that in my life. I've never been around another person who's experienced that. So I think that especially was really, really helpful. But I mean, ideally, I think every trainer or every teacher would love to like have like a level of training in most medical emergencies, or as much as we can. But like you said, it's really time consuming. But
well, I'm just also sort of wondering too, I mean, another component of this legislation, it's not just training every staff member in the building, but also age appropriate for all of the students. And I'm curious, should seizure be the only one, or should we be having empathy for individuals who have EpiPens or can't eat in certain things because of allergies and those types of things? I'm just curious about that.
I think yes, I think in my experience, a lot of students do have a lot of empathy for allergies and inhalers and medications, and students who need to have medication administered or who need to go to the nurse's office on a regular basis to get something. Again, I think that this particular situation was a little bit different because I think, like me, most students hadn't seen that before.
Okay.
And so I think like, I know seizures can look different in a lot of different ways, but like they can look very scary to people who've never seen them or experienced, or who are experiencing them for the first time. And so I think like the students in like Ava Ellis's class knowing more about it, I think is like a really helpful thing for students who are experiencing it, because it's just not quite as common or well known, or kids aren't as exposed to it.
Okay, thank you. Dr. White, are you still on? I see your box, but I'm not sure if you're still here.
Sorry, I was muted. I'm here. Trying to get off mute.
No problem. Thanks so much for being here and for your testimony on behalf of the association. You know, it is a little surprising to me, I guess, that we don't have a requirement in terms of a CPR plan, because we do have defibrillators that are sort of distributed amongst. There is yesterday I had a sort of a side conversation with Councilmember McDuffie. We were talking about just sort of the growth of athletics just in general. And I know from a prior hearing that we had with the state athletic office, they have been, going from not just high school athletics, but now we have programs in middle school, and they're trying to do things in elementary school as well. But we don't have the same requirements for the lower grades around AED defibrillators, and then having someone trained in sort of CPR on campuses. Would you suggest that that be the case?
Yes, I think a lot of these conditions do start around puberty. So having a focus on high school makes sense to me if that's where we start. But ideally, yes, you would have somebody who has the awareness in any athletic event where kids are participating. I think like if I have more time in my testimony, I would have tried to convey like how scary it is to be in a situation where a child collapses on a field. And I mean, you may have seen those football players that on television, like how terrifying that is. And so to have somebody who knows what to do is really crucial, because your brain just is not firing in the same way that it normally would. And, a 7-year-old collapsing on a baseball pitch will just send everybody into panic mode. So having somebody that is really ready to respond to that is, I think, ideal for any athletic event that kids are participating in.
Great. Thank you. I'm over my time. Thank you, Mr. Chairman.
Your co-chair, if you have a few more questions.
No, I'm okay. Thank you. Thank you to all the witnesses who testified.
Thank you, Councilmember. Councilmember Allen?
Thank you all very much for your testimony. Ms. Somerville, I really want to thank you for sharing your story. Our families know each other very well, and I will say it was one of the more moving and powerful moments I've had when I was able to join you at the firehouse on New Jersey Avenue, to honor and recognize the Capitol Police officers and the DC Fire first responder that acted quickly and helped save your life that day. I think, as you noted in your testimony, it was that fast action and training and preparedness that changed the course of that day for you, for your family, and for our community. And we're all very grateful for the actions that they were able to take, and obviously the work that went into putting them in a position to be able to take that action. I also think you've turned your story into a call to action for all of us, and I really appreciate that. You can certainly count on my continued support for this legislation. I hope we can get this passed quickly and see it implemented. Also, I was just noting the other day, the additions we've even made in our own Wilson building, putting automatic defibrillators in every council office. We'll never know when we need it, but it certainly makes us better prepared and more likely to save a life because it's there. So I just wanted to thank you for being here today and consistently raising your voice and sharing your experience and your story to help call for the steps we all want to take. So just thank you for doing that. I wanted to turn briefly to Mr. Teneo, if I can. I think one of the things that I was listening to Councilor Robert White's opening comments and talking about the feel of confidence, right? And we had talked about this before in our office. And as we think about setting these steps up, can you just share a little bit more from just as a student who's willing to speak about this issue and talk about your own experience, the things that are in this legislation, the having teachers that are trained, having schools provide training every 2 years for staff, providing age-appropriate epilepsy and seizure awareness education for all students. What is it about those steps that help give you and what I hope would be other students confidence about being able to be safe at school?
Well, I think the training is just, I'm able to feel comfortable knowing that if I do have a seizure, that my teachers will be able to help me and make sure I don't like hurt myself if I do have a seizure. The awareness, I think, is just, it's nice to I don't know. I don't know. The social stigma will be less, right? So kids won't they won't mistreat me, right? For I kind of just be treated I don't know. I want to be treated like I have asthma or something like that, not like a big scary thing that I don't know. He's like a weirdo or something like that. Does that make sense?
It does completely. And I really I appreciate the way you're talking about that as well. About not only do we want to have teachers, fellow students be more aware and be more prepared to act if necessary, but also about reducing stigma, because a lot of that stigma really comes from people just not knowing what does different mean. And I think about frequently how do we help normalize things? And I think about I have 2 kids that are going through elementary school and now starting middle school, and whether it's somebody who needs to have an EpiPen, whether it's somebody who has a nut allergy or asthma or anything else, it's actually quite just normalized to where because for those types of things, there's a lot of student conversation, class conversation about awareness, about what should we all do if we see somebody having a reaction. But the same is not true of seizures and epilepsy. And so that unknown and that different can lead to that type of stigma you're talking about. So I just really appreciate you giving voice to that, because I think that's an important part of this. It's not only about making sure you have the care and support you need to be able to make sure that you are kept physically safe, but I think that you're spot on in your advocacy here about what it means to destigmatize and make sure that every hour of the day, whether there's a seizure happening or not, there is a normalcy and awareness and a support that creates that safe space we all want. So I really appreciate that. Oliver, again, I know you're not alone in this, but I know since I've spent the most amount of time with you working on this bill, just really appreciate your braveness and being able to speak about it, bring it up, advocate for it. I know we've been in touch over the last couple of months as we've moved towards this hearing. I, again, am thrilled with the chairman and Chair Henderson holding today's hearing so we can take the next steps on this and just keep up the pressure on all of us to get this over the finish line. And thank you for bringing your voice to this. Thank you.
Thank you, Councilmember Allen. Councilmember McDuffie.
Thank you, Chair, and thank you to all of the witnesses who have taken time to share their testimony, particularly those who shared, I think, some really deep and compelling personal stories with the council. It really is testimony like that that helps to shape some of the policies and laws that we consider here at the council, and I really appreciate it. You all taking the time to provide those stories. I want to ask Stuart Berlow, thank you for your collaboration and that of the American Heart Association, working with me and my team on legislation over the years. As you know, the district requires AEDs in schools, and that's important. And I'm glad that we've gotten to the point where we already have that here in the District of Columbia. But I'd love to hear your thoughts about how the accessible technology in and of itself may not be enough without a response plan. And if you could, share why you think a cardiac planning and response plan as required by this bill is necessary and not duplicative of some of the existing laws on the topic.
Yeah, thank you for that question. Frankly, you were ahead of your time back in 2016. At that point, there were very few places that were requiring AEDs in schools. The district was one of the first jurisdictions to do that. Now there's several more that do. I think I would go back to Dr. White's testimony from a few minutes ago when she was describing the chaos surrounding someone collapsing, going through cardiac arrest. She, as a trained physician, knows what to do. And as she described it, everyone else around was in that panic and not knowing what to do. And even if they did not know what to do, even if they did know what to do, their brain is firing and the adrenaline's going and they were in a panic. I think that's why having this plan is so important. As I think it was Councilmember Allen who reminded us that you all have been terrific in putting AEDs in each of your offices, which is great. But before that, there were a handful scattered around the building, as there are in other public buildings here in the district, and some private buildings as well. But what we know, the research now tells us, is that if a machine on the wall, if people don't know what to do, it's just a machine on a wall. So if people don't know that it's in your office or it's in certain hallways here in the Wilson building, and someone collapses somewhere in this building and nobody knows what to do and everyone starts panicking, no one knows either hopefully someone will call 911, but if nobody knows CPR, then that machine, all it is a machine on a wall. You might as well not have it because you didn't have that plan. You didn't have people who were specifically trained and know what to do. And the training that we're talking about is very simple. We're saying someone's job is to call 911. Someone's job is to go get the AED. Someone's job is to start hands-only CPR. Very simple things that can lead to something as impactful as what Delia was talking about, of a life literally being saved. So again, I think when, back in 2016, when you put forward the legislation for the AEDs, that's what the science told us is at the time is what we needed. Now, many years later, we know that might not be enough.
Thank you for that. I want to turn to Dr. White and really appreciate your testimony, as I said earlier, as I do appreciate the testimony of Commissioner Prinzo and Delia Somerville. And I know the advocacy from Jude Mabonnet. But Dr. White, you provided some really tragic examples of why having a protocol in place and getting immediate care is critically important. Are there any parts of this law as proposed that you think needs to change or be tweaked, or any additions or clarifications to the cardiac emergency response plan that are needed? I know there's some testimony that we got where a witness recommends expanding the bill to include child development facilities. And so just your thoughts briefly on areas that we might be able to enhance this bill.
I think it may be that each individual school, their protocol may look different depending on their environment, depending on the resources that they have. And I think allowing for some flexibility in terms of developing the protocol is appropriate, depending on what the resources are of the school and who could be involved in that development. I think the broad strokes of the law that require that there is some written, understood protocol in place is really like the meat and potatoes of what we really need. But allowing schools to have some flexibility around how that's developed, I think would be okay. I do think having like a written protocol and also rehearsing that protocol, like having drills potentially could be really helpful. I know even at our medical facility, we've run drills, once a year, and people forget because they haven't done it in a long time, or they forget how to turn on the machine or whatever, or they haven't checked the batteries in the machine. That also has come up. So maybe, having legislation that requires that kind of testing, or just revamping of the legislation, revamping of the protocol, on a semi-regular basis could also be helpful.
Thank you so much. And thank you to all the witnesses who've testified and those who will be testifying today. I'm over my time for this round, but I appreciate your advocacy, Dr. White, and all the others who have helped us get to this point, and appreciate Chairman Mendelson and Chair Henderson for holding this hearing. Look forward to working with you all on this bill.
Thank you, Councilmember McDuffie. Councilmember White.
Thank you so much, Chairman, and thank you to all the witnesses. These are just really powerful testimonies that illustrate why these protocols and procedures are so important. Let me start with Molly, Ava's mom. How does it feel to send Ava to a school where every teacher has had this training?
Thank you for asking. I actually am also a teacher at that school. So when I have to go take my class on field trips, or when I'm in the middle of state testing, or when I'm not available, I know she's fine. I'm not constantly checking my phone. I'm not constantly worried about her. My biggest concern is when she goes to middle school and she's not in a building with me or with people who are trained. Right now at the school she's at, I would go on vacation and be fine with her being there, because there are so many people there who advocate so hard for her. And so many of them submitted testimonies today. But having her at that school, it's an indescribable weight off my shoulders. Having a kid with epilepsy is terrifying, especially when you don't quite know what to expect. She was only diagnosed a few years ago. So as we've navigated her life and what it looks like now, having people at her school who are in her corner means more than I can even explain. They keep her safe even if I'm not there, if I can't do it.
Yeah, I appreciate that. As a parent with young kids, when you send your kids to school, that worry or anxiety, particularly if you know that there is something serious that may come up that folks may not know how to address. And Oliver articulated this incredibly well when he sat down with me and Councilmember Allen to talk about this bill. Oliver, you addressed some of this in your discussion with Councilmember Allen a bit ago, but what kind of support do you believe is most important for schools to provide to students with epilepsy?
I'd say probably just like reassurance, I guess, just more of just like a support, knowing that they know what to do and knowing that I can count on them in case something does happen.
And I think that, that confidence, hearing that from a student and from a parent, I think underlines why these protocols are so important. And for Caitlin Arbuckle, how long did seizure safe training take?
It was one session. I don't know, maybe an hour and a half at most. It wasn't it definitely wasn't the longest I've had as a teacher. But it was really informative, and just like it taught me a lot in a short amount of time, but it wasn't as time consuming as a lot of other trainings I've been through.
Right. Excellent. And how did it help you recognize that someone is having a seizure?
Well, in this case, this student has experienced seizures before, so he knew that he was getting ready to experience it. So he was able to verbalize, I think I'm about to have a seizure. And I was able to like have a moment of like panic and then think back to like, okay, no, I know exactly what I need to do. Which was really, really helpful. So in this situation, but I also learned that that's not always the case, that students don't always have it. Sometimes they can look a lot differently, which I guess I knew, but I didn't really know until my training, that sometimes it can be a student like zoning out and staring off into space. It can be a student having like, can be in their chair, they can be laying down, they can have lots of body movements. And so I think that was really helpful for me as a teacher, just to be able to recognize different signs in students if it happens again in my classroom.
So, well, thank you for that. I mean, it sounds like this is certainly not an overly burdensome training, and that the payoff is just incredible.
Yeah.
So thank you very much. Thank you to all the witnesses again, and both to chairs Mendelson and Henderson.
Thank you, Councilmember White. Thank you to each of the witnesses. Your testimony has been very helpful. You all are excused, and I'm going to call the next group of witnesses. Kaylee Wilshire, Jude Mabone, Ashesh Patel, Andrew Jones, Margaret Coretti, Tierra Dupree, Britt Dorfman, Latressa Murray, Ken Edmonds. Kaylee Wilshire, we think is not here. Jude Mabone. Turn your microphone on. It's on. Oh, it's
okay.
on. Yes.
There we go. Good afternoon. My name is Jude Mabone. I am Miss District of Columbia 2023, and I'm also a survivor. A year ago, America watched as Damar Hamlin suffered from sudden cardiac arrest during a Monday night football game. Thankfully, his trainers were well equipped to save his life. But for 2,000 kids this year, that is not the case. I had my first heart attack when I was 16 years old during a summer of cross-country practice. My coaches had no idea what was going on, and they didn't understand the severity of what was happening. And so as a result, they left me to wait for emergency services by myself. While my condition is very uncommon, sudden cardiac arrest is not. In fact, it is the #1 killer of student athletes and Americans under the age of 25. We have an opportunity here to empower coaches, school administrators, teachers, and staff to step up and act with confidence when cardiac emergencies happen. We must create plans so that when emergency strikes, individuals know what their designated role is in that life-saving action. It is not enough to just have CPR and have AEDs on site. Cardiac emergency response plans are the difference between life and death. It is what saved Damar Hamlin. It's what saved Bronny James, and it will be the thing that saves the DC student athlete when emergency inevitably strikes. So I urge the council to pass this legislation to mandate cardiac emergency response plans in all of our DC public schools. Every student athlete deserves the right to play, but they also deserve the right to live. Thank you.
Thank you, Ms. Mabone. I think I mispronounced it before. Mabone?
Mabone, yes.
Mabone. Thank you. Ashesh Patel?
Yes, hello. Can you hear me?
Yes.
Yes, hi. I am the president of MSDC and a primary care doctor working in Washington, D.C. As you may know, MSDC represents every physician in the DMV, and specifically, we advocate on behalf of all physicians practicing in and licensed by the district. I am testifying today in favor of B 25-570, MSDC also supports B 2551 and will be giving written testimony on that bill later on. I've already given written testimony for B 2570, which I will not repeat here. I simply want to reiterate that cardiac emergency response plans are very important in order to make sure that the AEDs already required in schools will actually be useful for saving the lives of DC residents. So B 2570 is quite important. And then additionally, I was going to say that the lifetime prevalence of epilepsy is higher in African Americans than whites. So B 2571 is also important for DC residents specifically in Ward 7 and 8. Thank you.
Thank you, Dr. Patel. Andrew Jones. Margaret Garrity. Deira Dupree.
Good afternoon, Chairman Mendelson, Councilmember Henderson, and members of the Committee of the Whole and Committee on Health. My name is Deira Dupree, and I'm a resident of Ward 7 and have worked in the education and youth sector for the past 7 years. Thank you for the opportunity to testify before you all on the Cardiac Planning and Response Amendment Act of 2023. This bill, if passed, would be effective starting in school year 2024-25. The bill was written to ensure that schools have a cardiac emergency response plan that incorporates evidence-based elements recommended by the American Heart Association, American Red Cross, and other nationally recognized organizations. The bill requires all schools to develop a CERP with local emergency responders when incidents of cardiac arrest or similar life-threatening emergencies take place on school grounds. The bill also requires middle and high schools with athletic departments or programs to develop a CERP to respond to incidents involving students experiencing cardiac arrest or similar life-threatening emergencies while attending or participating in a practice or event on school grounds. Pursuant to existing law, DC Official Code Section 1-327.56, schools are required to have AEDs on campus and made readily available for athletic events. Also, every high school athletic coach, trainer, and school nurse are required AED use and CPR training. Furthermore, existing laws require schools to establish procedures for responding to cardiac arrest, but they're not required to have evidence-based plans to help guide these procedures. Each year, nationally, more than 356,000 cardiac arrest incidents occur outside the hospital, with 90% resulting in fatalities. This is because only 40% get immediate help they need before emergency responders arrive. Locally, the district has seen the effects of not having evidence-based plans in place. In the district, there's an 8.3% overall cardiac arrest survival rate, 2% lower than the national average, but over 2,000 AEDs across the city. Many of us heard about Bronny James collapsing during basketball practice last July and going into cardiac arrest. Thankfully, the University of Southern California had a plan in place which allowed members of the team's medical staff to restore his heartbeat using CPR and AED. This is just one example of what an emergency action plan can do as far as saving lives. If the plan had not been in place and staff didn't respond as quickly as they did, the outcome could have been much different. Cardiac arrest can happen to anyone, regardless of age, health, or fitness. A carefully coordinated response to these emergencies can help reduce deaths in school settings and ensure that chaos doesn't lead to improper or absent response. Data shows that CERP can increase the chances of survival after an individual goes into cardiac arrest by 50% or more. Preparation is essential to saving lives. The district isn't alone in its desire to introduce CERPs. Several states, including Florida, Georgia, Kansas, Michigan, Maryland, Mississippi, Tennessee, Virginia, and West Virginia, have introduced mirroring legislation to the Cardiac Planning and Response Amendment Act of 2023. Congress has also begun developing legislation on this matter in the HEARTS Act. The correct congressional version of this bill requires the U.S. Department of Health and Human Services to, among other things, establish guidelines regarding the placement of AEDs in schools and child care centers, establish CERPs, and include provisions of much-needed federal support to purchase AEDs and create CERPs to conduct AED training. I support the intentions of this bill and believe that it's necessary to pass.
Ms. Dupree, you're over your time.
Okay. Can I say something real quick?
Well, actually, I'll ask you a question when we get to questions.
Okay.
Thank you. Britt Dorfman?
Hello, my name is Britt Dorfman, and I'm the Senior Manager of Grassroots Engagement and State Policy for the Epilepsy Foundation. I'm also a resident of Ward 1. Thank you so much for holding this hearing and providing an opportunity for public testimony on B 25-571, the Seizure Safe Schools Amendment Act of 2023. The foundation is proud to support this legislation and is encouraged by the momentum across the country. About half the states have passed Seizure Safe Schools legislation, including our neighbors, Maryland and Virginia. We hope DC will be next. Epilepsy is a condition of the brain that causes reoccurring seizures. It's the fourth most common neurological disorder in the country. It's a spectrum condition comprised of many diagnoses, including an ever-growing number of rare epilepsies. There are many different types of seizures and varying levels of seizure control. Seizures are common and can happen to anyone at any time, anywhere. Approximately 1 in 10 people may experience a seizure during their lifetime. An individual may not necessarily have a diagnosis of epilepsy if they have a seizure, such as if it is their first time. Seizures are also associated with other medical conditions such as high fever, low blood sugar, and head injuries. Therefore, recognizing the different types of seizures and how to respond effectively and appropriately can be life-saving, not just for students with epilepsy, but anyone in the school. In my role, I've had the privilege of working with hundreds of teens living with epilepsy from across the country, including their parents and caregivers. I've used seizure first aid, and I know it can be a scary experience if you do not know what to do in those situations. The Epilepsy Foundation, through our work with the CDC, has designed trainings geared towards school personnel and school nurses that encompass seizure recognition and first aid response. These trainings are certified for continuing nurse education credits for school nurses and continuing education credits for certified health education specialists. School personnel receive a certificate of completion. The training is free and can be provided either in person or online on demand. Direct access to school nursing and other health services, as well as disease-specific education, has been shown to improve health and academic outcomes among students with chronic health conditions. This bill would help keep students who experience seizures safer at school and create a supportive environment. Thank you so much for your time, and we hope that you pass this bill.
Thank you, Ms. Dorfman. Latressa Murray.
Hi, good afternoon, everyone.
Good afternoon.
This is in regards to the seizure safe bill. I am testifying on behalf of my son who was diagnosed with epilepsy in February of 2023. He had his first set of seizures in December of 2022, but we wasn't aware that he was having seizures at the time. So it wasn't until 2023 is when he was finally diagnosed. It will give me great relief having more school staff members trained in knowing what to look out for with children who are epileptic and the different types of seizures individuals have. My son is 8, who suffers from focal seizures, absent seizures, and he's also experienced a tonic-clonic seizure. His seizures are yet to be controlled, and he's been on different kinds of seizure medications. He has been virtual with schooling since the pandemic, and unfortunately, virtual isn't catering to the elementary anymore. Now he's starting back to in-person in this August. It truly bothers me not being able to monitor him and hoping that in the event he has a seizure, that he will quickly get the help he needs. Sometimes it would look as if he's daydreaming and staring off, but in reality, he's having a seizure. The Seizure Safe Bill gives parents and guardians a peace of mind, knowing that someone is trained to help them in an epileptic event and knowing how to administer rescue medication for seizures lasting more than 5 minutes. This bill will help bring awareness in schools to look out for triggers and can help stop seizures before it starts. Thank you for hearing my testimony.
Thank you, Ms. Murray. Ken Edmonds.
Good afternoon, Chairman Mendelson, Chairwoman Henderson, and distinguished members of both committees. My name is Kenneth Edmonds. I serve as Vice President of Public Policy and Government Affairs for the National Football League. I'm pleased to testify today on behalf of the NFL, as well as the Smart Heart Sports Coalition. The League and the Coalition strongly support Cardiac Planning and Response Amendment Act 2023, and we urge this committee and the entire council to pass this life-saving measure as soon as possible. Following the life-saving response to Buffalo Bills safety Damar Hamlin's injury and inspirational recovery, the NFL led the launch of the Smart Heart Sports Coalition in March of 2023. The coalition includes major sports leagues and organizations, as well as leading patient and health advocacy groups like the American Heart Association, nearly 40 stakeholders in all. We have come together to advance a single goal: to save lives. We want BC and every state across the country to have in place the 3 evidence-based policies proven to prevent fatalities from sudden cardiac arrest among student athletes. If adopted, the same core elements that were reflected in the response that saved Damar's life can also save the lives of student athletes and others who may one day experience sudden cardiac arrest in the District of Columbia. They are readily available AEDs at school athletic venues and events, written and regularly rehearsed emergency action plans tailored to these venues, and CPR education and training for coaches. Adopting these policies is critical, especially given that sudden cardiac arrest is the leading cause of sudden death among young athletes. And as you heard in previous testimony, 4 in 10 sudden cardiac arrests among young people occur when they are engaged in physical activity. This bill will accomplish the goal. It will save lives. As you've heard in previous testimony, the legislation requires middle and high schools with an athletic department or organized athletic program to develop CERPs, cardiac emergency response plans, that build on and enhance current law. Councilman McDuffie asked a key question when he asked what can be done to enhance this. Our only suggestion would be it's not enough to have a plan. The plan has to be posted, just widely distributed, regularly rehearsed, and updated annually if necessary. We've heard how when someone is suffering a sudden cardiac arrest, it's a time of deep stress, high anxiety, and practicing that cardiac emergency response plan is critical so bystanders can become lay responders.
Thank you, Mr. Edmonds. That concludes the testimony of this group. For questions, let's see, Ms. Dupree, I cut you off, but I have your statement, and you were about to, I think, discuss some issues you had with the bill. Please don't use up all my time, but do you want to speak to your issues?
Yes, so my issues with the bill is mostly that it includes the schools, which is defined by DCPS, or schools are defined as DCPS charter, parochial, and one other, but it doesn't include child development facilities. And I think that is important because 10 to 15% of like all infant deaths happen in child development facilities. More recently in Ohio, last month, a 2-year-old, and I have a 2-year-old, passed away in a child development facility. She went into cardiac arrest and no one was trained on how to assess her, and she ended up passing. So that's one of my issues. My other issue is the time frame. That school year 2024-25 is about to start in a month, and I just don't think it's going to be enough time for proper engagement. And lastly, again, it's back to the child development facilities.
I didn't understand the comment about the time frame. I mean, we pass legislation when we pass it. We're having this hearing in July. The council doesn't come back from recess until September. Are you lamenting that this won't be in effect before the school year, or some other?
I'm saying I feel like if it does go into effect by the time the school year starts, at the end of August, it's going to be rushed. And I work in schools, and I just see how a lot of the times the policies, they come into place and they're not actually implemented. Like there's policy implementation shortfalls.
Yeah. Well, given the process, which includes congressional review, assuming we move forward, probably nothing would be effective until the middle of the school year, and probably we would consider the timing in terms of the DCPS or the schools having to implement it. Thank you for your testimony. Ms. Dorfman, I had a couple of questions for you. Actually, before I forget, Mr. Edmonds, we don't have a copy of your statement, if you could provide that.
I sure will, Mr. Chair.
Thank you. Ms. Dorfman, in your statement, you said the Epilepsy Foundation, working with CDC, has designed 2 trainings geared towards school personnel and school nurses that would encompass seizure recognition and first aid response. Is that that training more focused on the medical aspect or on the more general awareness?
The school personnel, has several key components that incorporate the seizure recognition and first aid response. There's one module for the school personnel, and there's several actually for school nurses on seizure recognition and first aid. There's another one on administering medications, and then a couple of others that are optional.
So the first module you mentioned, which I think was just recognition or
School.
awareness, how long is that?
It's 50 to 70 minutes. There's a pre and post test, so it can take folks, however long it might take them, but the training as it is about 50 minutes. We do have other seizure first aid courses that are 30 minutes that could also be used, especially if every 2 years they just need a refresher, they can take the 30-minute course.
Ms. Dorfman, you've heard some of the statements that Bill 25-751 is duplicative of what the council adopted last fall. What's your thinking on that?
I definitely understand the concern, but I think the other components included in B 25-571 are more inclusive with the seizure action plan and the training for all school personnel in general first aid response. Administering medication is incredibly important, and we're open to having conversations about the duplicativeness of the bills. And as well as the student age appropriate training is also important. So I think taking the bill as a whole, I understand the concerns with the other bill that was passed, but I think in order to provide students with a safer environment, looking at all of the components that are included in the bill are just as important.
Thank you. Council Member Henderson.
Thank you, Mr. Chairman. Ms. Dorfman, in the other jurisdictions who require this, who is the person who keeps track of whether all of the teachers in the building have the required trainings and are up to date on the required trainings? Whose responsibility is that?
It depends on the language in each of the bills, because in certain circumstances, the Epilepsy Foundation training is mentioned, and that's the one that is used. There are other organizations that have their own training as well. So we are able to keep track of all of the folks that complete the program, the modules through our learning management system. Because it is an unfunded mandate and the training is free, keeping track can be difficult, and it could be the schools would have to do a little bit of management in that area.
Okay. As I'm looking at this, that's one area we have had a lot of back and forth, and I'm sure the government witnesses are going to speak to this, although Asi is not testifying. One of the back and forth that we've had is it the state education agency's responsibility to ensure that the schools have all the required personnel trained? Is it the school responsibility? Is the district's responsibility? And I think that that is one thing that I'm going to ask a question about, although I don't think that
We've
Director,
definitely
you
seen, sorry to interrupt, we've definitely seen departments of education in other states take that on. But because each school district is very different, they all have their own kind of practices and policies in that area. So it can be really tricky.
It will be tricky in DC too, because we have 62 different school districts who operate here. So that will also add. But I was just curious in terms of the that part in terms of administration. I appreciate the rest of the witnesses for their testimony today. I don't have any other further questions, Mr. Chairman. Thank you.
Thank you, Councilmember. Councilmember Allen?
Thank you, Mr. Chairman. I actually had to step away for a moment, so I don't have any questions, just appreciation for everyone's testimony today. Thank you very much.
Thank you. Give me just a second. That's going to conclude our questions for you all. Thank you, each of you, for your testimony. We're going to turn now to the government witnesses. I'll call both of them. Robin Diggs Purdue, Senior Deputy Director of Community Health Administration at the DC Department of Health, and Andrew Edwards, who is Assistant Chief, DC Fire and Emergency Medical Services. You don't get a timeout. And which one of you wants to go first? You've been joined by a third person. You are. How about if you turn on your microphone?
Good afternoon, Chairman. Dr. Deatra Bryant Mallory, DC Public Schools.
Okay. So you're here to answer questions, but you don't have a statement.
I do not have a statement, but I'm here to answer questions. That is correct.
All right, thank you.
All right, I'll get started.
All right.
All right, good afternoon, Chairman Mendelson, Chairwoman Henderson, and council members McDuffie, Allen, and Robert White. My name is Robin Diggs Purdue, and I am the Senior Deputy Director of the Community Health Administration, also known as CHA, at the District of Columbia Department of Health. On behalf of Dr. Ayanna Bennett, Director of DC Health, I'm providing testimony on the Seizure Safe Schools Amendment Act of 2023, which would enhance the safety and support for students who may experience a seizure in district schools. While we support the intent of this legislation, we have several recommended changes to ensure it is able to effectively support students. Nationally, seizures are the third most common medical emergency that occurs in schools, significantly impacting the academic and social experiences of students. According to the Epilepsy Foundation, it is estimated that 470,000 children in the US have active epilepsy. Seizures can vary in severity, ranging from brief lapses in attention to full body convulsions, each requiring different levels of response and management. This diversity in seizure types highlights the need for comprehensive support and effective management strategies within schools to protect the health of students with seizure disorders. Undiagnosed or inadequately managed seizures can result in dangerous health complications, affecting a child's overall quality of life. For example, status epilepticus, a condition where seizures last too long or occur too close together without recovery in between, can lead to permanent brain damage or even death if not treated properly. Ensuring timely and appropriate management of seizures is critical to preventing severe outcomes and maintaining a safe and supportive learning environment for students. DC Health's electronic health record system collects data from schools served by our School Health Services program to track student-specific prevalence of medical conditions. As of July 2024, we have identified 699 students served by the School Health Services program with seizure disorders of all levels. 274 of those having a seizure disorder requiring regular or coordinated care during school hours in the health suite. Recognizing that this estimate may be a slight undercount due to some public charter schools not yet utilizing the EHR system, we are working to ensure comprehensive data integration with those schools. Our aim is to improve the creation and submission of comprehensive management plans to ensure every student with a seizure disorder has an up-to-date and effective care plan on file. The Seizure Safe Schools Amendment Act of 2023 aims to enhance the safety and support for students with seizure disorders in schools. Key provisions of the bill include requirement for individualized seizure action plans for students diagnosed with seizure disorders, ensuring that these plans are part of the student's file and accessible to relevant school personnel. The bill also mandates that schools provide training for every 2 years to school personnel and volunteers with direct contact and supervision of children on seizure recognition and first aid response. It requires that at least 2 teachers or administrators at every school be trained in seizure recognition and administering emergency seizure medication. Additionally, the legislation requires schools to offer age-appropriate education programs for students on seizures and following guidelines from the Epilepsy Foundation of America. DC Health supports the implementation of individualized seizure action plans for students with epilepsy and other seizure disorders. However, DC Health does not advocate for this requirement to be codified, as it limits the ability for DC Health and clinical and educational partners to make future changes as quickly as needed. Instead, should DC Health make this a policy change, as it does for other conditions, including asthma, it will allow for a more strategic response to the health conditions being faced by district students. Currently, the Universal Health Certificate is the only form mandated by law to document a student's health plan. And individualized health plans and medication plans are also used, but they're not legally required. The addition of the seizure action plan will provide clear guidance and awareness, potentially closing any gaps in care and coordination that may currently exist. These plans will provide explicit and clear details about a student's seizure management, ensuring better data for our health suite staff, and that trained school staff can also respond appropriately. For school staff, the existence of seizure action plans means increased awareness and preparedness in recognizing and responding to seizures promptly, thereby creating safer and more supportive learning environments for our students. DC Health proposes that DC Health's authority under the regulatory framework created in the Access to Emergency Medications Amendment Act of 2023 to create a comprehensive plan for managing seizure medications in school be utilized. Given the complexities of individualized health risks for students with epilepsy, more research is needed to determine the safety and appropriateness of undesignated seizure rescue medications, including the FDA-approved emergency nasal spray for seizures. While we have not ruled out the use of undesignated medications, we are currently unsure of the potential impact on students and want to ensure that the benefits outweigh any potential harm. This approach ensures student safety and alignment with DC Health's authority to propose rulemaking, aiming for a clearly defined implementation. DC Health fully supports training school staff on recognizing and responding to the health needs of district students. The Administration of Medication Program currently trains at least 2 staff members at each school to respond to health-related situations. AOM trained staff support students by administering medications when needed, including on campus or during school field trips. This bill mandates that 2 staff members should have training specifically on seizure recognition and medication administration. The current AOM curriculum already includes seizure recognition and medication administration, but DC Health will further evaluate the curriculum to ensure that it meets all the requirements within this legislation. DC Health supports training for school staff on the recognition and response for various health concerns such as asthma and including seizures. This comprehensive approach is beneficial as it equips school personnel with the knowledge and skills needed to address a range of medical emergencies, ensuring a safer environment for students. Through preparation for different health scenarios, staff can respond swiftly and effectively, reducing the potential severity of medical incidents and promoting overall student health and well-being. Therefore, DC Health supports providing the mayor with broader authority to establish training programs for recognition and response for multiple health concerns across all schools. And we advocate for a broader, more comprehensive approach to enhance the consistency and quality of health emergency response and ensure that school staff are adequately trained to address various health concerns when appropriate. Finally, DC Health advises against requiring training for students on seizure recognition and response. This requirement may create misguided expectations that students are responsible for recognizing the signs of seizures during a medical emergency by their peers, and that's something that wouldn't be appropriate for them to address. Instead, DC Health suggests alternative methods such as school-wide assemblies, or health literacy education to raise awareness and promote understanding of seizures among students. This responsibility falls more appropriately within the purview of our local education agencies with the support of the Office of the State Superintendent of Education, ensuring that educational content is age appropriate and effectively communicated. I want to thank the Committee of the Whole and the Committee on Health for allowing DC Health to share feedback on this legislation and recommendations on how to better address the unmet medical needs of district students, particularly those related to seizures. I look forward to continued collaboration on advancing the health and wellness of students and am available for any questions. Thank you.
Thank you. Assistant Chief Edwards.
Good afternoon, Chairman Mendelson, Council Member Henderson, and staff. I am Andre Edwards, Assistant Fire Chief of EMS Operations for the District of Columbia Fire and Emergency Medical Services Department. I am pleased to testify on behalf of the administration on Bill 25-570, the Cardiac Planning and Response Amendment Act of 2023. Bill 25-570 require each school in the district to develop a cardiac emergency response plan, or CERP, to identify the appropriate school personnel to respond to a cardiac arrest or similar life-threatening emergency on school grounds, including for the athletic practices and events. A CERP is a written document establishing specific steps to reduce death from cardiac arrest in any setting, be it school, community organization, workplace, or sports facility. The legislation mandates that CERP include who will respond in case of an emergency and how they will respond, and how staff will be trained to that effect. The legislation also requires school officials to integrate best practices for engaging the local emergency services and automated external defibrillator AED placement into the plans. The administration supports this legislation with minor amendments. Improving patient care and outcomes, including the cardiac arrest survival, is a key priority of Mayor Bowser and Fire and EMS. The department's focus on cardiac arrest survival resulted in survival rates increasing 10% across several internationally agreed upon cardiac arrest performance criteria from FY22 to FY23. This translates to 20 more patients being discharged from the hospital neurologically intact in 2023 compared to 2022. We had 69 neurologically intact survivors in 2023, the highest number of survivors the department has had since it began tracking outcomes in 2011. Cardiac arrest survivability increases dramatically when a cardiac arrest is witnessed by a bystander and the interventions to restore patient's heart rate begin quickly. This is where AEDs and CERPs come in. An AED will determine if the sick person has a shockable rhythm and will deliver a shock to restart the heart. In the district, schools and recreational facilities are equipped with AEDs for this purpose. Fire and EMS also administers the district's AED registry, which allows the public and the Office of Unified Communications, OUC, to access instantaneously up-to-date information on location of nearest AED to cardiac arrest incidents. There are 3,421 registered AEDs in the district, with 1,227 approved, location and maintenance state verified, and 2,194 pending verifications. As of May 2024, both bystander and call notifications by OUC use the AED registry. If a caller reports a cardiac arrest, the OUC call taker can instruct the caller to direct a bystander to the nearest AED and begin instructions on delivering telephonic CPR. At the same time, members of the public with the Pulse Point app on their phone will be notified of a report of a nearby cardiac arrest, allowing them to assist before first responders arrive on the scene. The fundamental purpose of a SERP is that while having a plan is critical, identified on-site personnel must be prepared to spring into action and know their roles, namely, recognize the signs and symptoms of sudden cardiac arrest, immediately access professional medical help by calling 911, start cardiopulmonary resuscitation, CPR, chest compressions, locate and bring the AED to the patient's side, administer the AED, transition care to EMS, and debrief to learn lessons from the incident. SERPs are common and easily found online, including on the department's website at fims.dc.gov. The department is also creating a standardized template for use across the district, regardless of business, organization, or affiliation. The department requires SERPs for AED purchasing using the district's new AED incentive program, offsetting the cost of purchase for small and local businesses, places of worship, and small rental and condo buildings. The administration proposes the following amendments to this legislation. First, the proposed bill will require school officials to work directly with local emergency service providers to integrate the SERP into the community's emergency medical service responder protocols. As written, this requirement would be administratively cumbersome in a jurisdiction like the district, where the fire and EMS is a sole governmental EMS provider and all schools are governed by the Office of the State Superintendent of Education. Rather than tasking individual schools with identifying model SERPs of varying quality, we recommend changing the requirement to direct OSSE in collaboration with the fire and EMS to develop model SERPs, which can then be adopted by individual schools. Further, the language to integrate the SERP into the community's emergency medical services responder protocols is vague as written and should be struck. The department's protocols direct responders to ascertain information where possible to assist in the delivery of care. This should be sufficient without additional legislative requirements. Second, the proposed bill provides for new requirements on first aid, CPR, and AED training, which are duplicative. The administration recommends the committees conduct a survey of existing legislative requirements across the code for this type of training to propose training standards and enhancements are not duplicative and or contradictory. If implemented as written, these additional requirements for new training would have a non-negligible fiscal impact. Members of the council, thank you for the opportunity to testify on this legislation. I, along with representative of the District of Columbia Health and District of Columbia Public Schools, am available to answer any questions.
Thank you, Chief Edwards. I didn't understand that last point you made, Chief. The administration recommends committees conduct a survey of existing legislative requirements across the code for this type of training and proposed training standards. If implemented as written, these additional requirements for new training would have a non-negligible fiscal impact. I'm confused.
So to implement the training and to follow the proposed bill as is written, it would cause impact to the fire and emergency medical services budget.
It would have a cost.
Yes.
The bill as written would have a cost.
It's not written specifically that it would have a cost, but in order to provide the oversight that is recommended, it would have incur a cost.
And if instead we follow use the language used in other statutes, that would probably reduce that likelihood of a cost.
Yes.
So the department with these several suggestions supports this legislation unequivocally.
Yes.
And you're testifying not just for the department, but for the executive.
Yes. So I'm here representing the department and Fire Chief Don Donnelly.
Yes, but you do say you're pleased to testify on behalf of the administration, so that suggests the executive branch. I'm going to ask this question of Department of Health in a second. Let me ask Dr. Bryant Mallory, a concern that I have, since I have oversight over education agencies is what are we doing? Are we doing something here that's just going to create one more burden, one more hassle for principals and teachers with, we'll start with the CPR bill.
Thank you for that question. As you know, at DCPS, our goal is to keep students safe and well cared for at school. And that requires that we partner with agencies such as DC Health and FEMS for public health guidance, as well as support in responding to emergencies. One of the things that is challenging for us is increasing mandatory trainings. We believe that our staff need to know what to do in the case of an emergency, but we also know that there are the right people for the right level of training. We need staff that know how to respond in the event of an emergency in terms of alerting and asking for help. And then we also have staff that are trained and ready and available to treat. And so it would be a lift for us to say that all DCPS staff must be trained.
All right, at the moment I'm blanking. The CPR bill, does that require all staff to be trained?
No, that is AOM staff.
And the seizure safe bill, as I recall, doesn't require all staff to be trained.
That is AOM plus the health suite staff.
So DCPS, not that you can speak for all of the LEAs, but your LEA at least doesn't see either of these bills as burdensome on the teachers.
We look forward to working with DC Health to figure out what makes sense. We believe that there is a lot in place already. For example, OSCE's standards around health education include training for students on how to respond to medical and other emergencies by grade 2. And so training for all students may be duplicative, unless we're talking specifically about seizures and cardiac arrest. But there is how to respond to emergency training built into the health standards.
I'm not sure I'm completely following, but my takeaway is that DCPS doesn't see that these bills would create a burden. I'm not trying to trick you into whether you support the bills, but you don't see that the bills would be burdensome on teachers.
We don't have concerns about the CPR bill. And the seizure bill does require all staff.
Okay. Ms. Purdue, I have to say that the statement is kind of leaves me a little bit confused. Now, you're only testifying with regard to the seizure safe bill.
Correct.
While we support the intent of this legislation, we have several recommended changes. But I didn't really see any changes recommended in your statement. Chief Edwards had some specific changes recommended in his statement for the other bill. What seems to come across is that the issue of seizures is already being addressed by the Department of Health, almost as if to say that the bill's not necessary. So can you help me understand whether in the department's view, we should adopt this legislation with some changes or that we don't need to adopt it?
So we're requesting that we be granted the authority under the Emergency Medications Act to actually develop a more comprehensive plan to address seizures, which would allow us to really spend our time working with our stakeholders to operationalize it appropriately. The other part around undesignated medications, we think there needs to be more consideration for that. We're not fully in support of that component. However, individual students can have rescue medications that could be prescribed by their provider, and those could be located at school and those administered, but that's different from an undesignated medication. And then the last recommended change was related to training for students. And we thought that that could, instead of a training, it could be more so incorporated into their health education curriculum or through school assemblies or other types of programming, not to be confused with the training that staff have to actually receive to respond in an emergency.
So let me see if I can remember the 3 points as you just said them.
Mhm.
The first, authority to give the department additional authority under the legislation that the council adopted last fall. Do
Right.
we really need to amend that statute? And Councilmember Henderson will pick up in a minute or two. Do we really need to amend that, or don't you have the authority under that legislation now?
So we do. So then it becomes a little duplicative. So we could include our approach to addressing seizures as part of the plan that we've developed for glucagon, as well as for epinephrine and for the other one,
So while you think that
albuterol.
let's see, the bill adopted last fall was the Access to Emergency Medications Amendment Act?
Right.
Okay, so it's not so much that needs to be amended as the department could take actions pursuant to that legislation to more specifically address seizures.
Correct. We have a plan that we have developed as it relates to glucagon and albuterol, undesignated medications, and we could incorporate a section that is responsive to a more comprehensive approach for addressing seizures.
Now, and that was the second point I think you made. I don't recall that the Seizure Safe Bill, Bill 25-571, spoke specifically of, what were they called, undesignated?
Undesignated, I thought it
It
did.
might have, I didn't read it with
Yes.
a medical eye,
Yes,
so.
yeah. I think the bill itself, the language in the bill specified undesignated, and that's the piece where we're not fully in support of undesignated.
And what is an undesignated medication?
That would be a medication that is on file at this school, but is not associated with a specific student. So it's not a specific prescription for an individual student, but it's medication that would be available to be administered to someone with a condition. It's appropriate for something like asthma, where the administration of albuterol, doesn't necessarily have any harmful effects. But the multitude of seizure medications that exist and the different types of seizures, it would be more appropriate to have additional time to consider whether undesignated would be the right approach for that.
I'm a little confused, but I'm also maybe a little out of my expertise here. Your statement says more research is needed to determine the safety and appropriateness of undesignated seizure rescue medications. If there's a
undesignated.
Yeah.
So again, you can have a rescue medication that is prescribed specifically for you. And that would be something that's administered by the health suite or by AOM trained personnel. And we would
Okay,
be in
but there
support.
would be another medication that's undesignated. It's still FDA approved, correct? it's not something that just, it's not something that hasn't been, the issue of designated or undesignated is specific to the student. Am I understanding you correctly?
No, undesignated means that there is medication, let's say in stock at the school that could be administered to a broader range of students. And they don't have necessarily a specific rescue prescription for them on file.
And you're saying the bill speaks to this?
That's what undesignated means. There is not a specific prescription provided to the school
For the
for you,
specific stu-
by your family.
But it's still a safe medication.
The issue is we need to do more research to determine if it will be safe in all instances, right? We talked about, and we heard testimony today about the variety of seizure-related conditions, the variety of medications that a person may be prescribed.
And now I forgot what the third issue was. Oh, the education for the students. I had one other question. I'll turn to my colleague. Are you testifying on behalf of the executive or on behalf of the Department of Health?
On behalf of Dr. Ayanna Bennett, the Department of Health.
All right, Councilmember Henderson.
Council member, if I may, before you go
Yes.
to Councilmember Henderson, I just wanted to clarify my earlier statement for DCPS. There is no lift for CPR training. And for the seizure training, we would like to co-develop and consult with DC Health to design something that would work for our 117 schools.
All right.
I hope that clarifies.
Yes, thank you. Yep. Councilmember Henderson.
Thank you, Mr. Chairman, and good afternoon to the witnesses. I'm going to focus my questions on the seizure safe bill because that's the bill that has been referred to the Committee on Health as well. Ms. Perdue, good to see you. I wanted to ask, so the bill requires that a student diagnosed with a seizure disorder have a seizure action plan on file. We know about action plans. We have them required for asthma. We have them required for hypoglycemia. What's the current protocol for students who we know have seizure disorders? Are seizure action plans already a common protocol?
There are seizure action plans that are submitted by providers. There are also medication plans that we have from providers. And then our health suites actually also develop individual health plans for students that help with operationalization of the action plan in that school setting. So even in cases, let's say where a student is able to self-administer their medication because they're supposed to take it before gym class, then the IHP might specify that that student is able to self-administer under the supervision of the PE teacher, for example.
Right. So this is already in practice, I guess, for students who are known to have seizures. So I guess the question is whether or not we need to require this across the board, or is this something that's already common practice?
Requiring the forms would be helpful because we do not have all of the action plans that we should for all of the students we know to have a seizure disorder.
That's correct. Let's take this opportunity in the summertime to remind families that they need to submit their action plans, not just for seizures, but for asthma, which we have I think maybe only 15% of the students that we know who have asthma actually have an asthma action plan on file. And like 71% of the students who have hypoglycemia have it on file. Okay. In your knowledge, have there been any instances where a student experiencing a seizure has not been properly treated at school because there was not a record of their condition?
We are aware of a few unusual incidents that occurred this past school year. And we know that there were 61 EMS transports due to seizure-related incidents at schools. None of those resulted in fatalities. But we expect that with the increase in staffing coverage, as well as being able to have action plans on file for all students that need it, would be very helpful in making sure that the proper care is provided and timely response occurs.
Okay. So let's talk about the training piece of this, because I think this is a little bit of where you guys are sort of raising some issues, as well as, because I'm hearing from DCPS as well, and I apologize. There is someone who's sent an email campaign and have 3,000 new emails in the last few minutes here. So the bill requires that each school should have at least 2 employees who have been trained on recognizing the signs of seizure and administering the necessary medication. My understanding is that seizure recognition is already covered in the AOM training that is required for 2 school staff. Is that the case?
That is correct, and the administration of medication as well. However, we are in the process of reviewing that curriculum just to make sure it has all of the components that are reflected in this bill, and also the, standards of the Epilepsy Foundation.
Okay. And then the bill also requires that the school provide training every 2 years to school personnel and volunteers with direct contact and supervision of children on seizure first aid. And I raised this with the public witnesses before. Why would we just do this for seizures and not for, asthma, not for allergies, not for other related things? What's your thoughts on that?
Yeah, I definitely think there's an opportunity for us to incorporate first aid training and, include other components. It could even possibly address CPR, but it's definitely an opportunity to have more comprehensive approach.
Okay. And so who would be the agency responsible for this? Would that be you guys? Would that be OSSI? Are we requiring every school or LEA to sort of manage this on their own? Because we didn't have any public charter school LEAs that testified today, but I would imagine they would say, we do not have the expertise in-house to develop our own trainings on these things, and would look to DC Health or to OSSI to lead on this.
Yeah, I mean, the schools fall under the direct, or the direct purview of OSSI, but we would be collaborating them to support the process, just like we're doing with the plan for undesignated emergency meds.
Okay. Apologies, the witness from DCPS, is this something that would happen before school started? In the middle of the school year? Have you all thought about when this would be incorporated into the traditional training calendar for school staff? Is this a professional development day? Help me unpack this.
Deidre Bryant Mallory, just to remind you of my name. We have not established this as a part of our PD calendar right now, and it would depend largely on the type of training that we design in collaboration with DC Health.
Okay. But I guess for you, Ms. Bryant Mallory, you're basically saying, though, you all would look to DC Health to lead on this, and it wouldn't be something that would come from DCPS itself.
That is correct. We would certainly want DC Health to take the lead on all public health related training.
Okay. Similarly, the bill also requires each school to provide age-appropriate seizure education, age-appropriate seizure education program to students on seizures and seizure disorders. Ms. Bryant Mallory, to your in your knowledge of the health curriculum that that the district already has, is seizure education already covered, or is this a new topic?
It is not explicitly covered, but there is certainly training that is within that curriculum that covers what to do in the event of an emergency at home or at school by grade 2. And there is a progression around safety and emergencies in other places within the matriculation of a student in those health education curriculum standards.
Do you think that it would make sense to require this type of education on other disorders?
We think our perspective at DCPS is that getting into condition-specific training can be a bit of a slippery slope. And we would be much more interested in collaborating with DC Health on a emergency response training that covers, responding in emergencies of different types.
Okay. So it seems as though you guys want to do some conversations between the agencies in terms of the best way forward. Am I hearing you guys right, Ms. Purdue?
Correct.
Okay. Let me quickly ask then a question about the CPR bill. In terms of similarly, so the bill requires that schools develop an evidence-based cardiac emergency response plan. My biggest question is, does it make sense for each individual school to have a separate CRP, or should LEAs create a standard one, as in this is just the standing operating procedure for everyone?
Good afternoon. So that was one of the recommendations that we proposed, is that instead of the schools having multiple different SERPs that would be that they would have to come up with, that we would assist the OSSI with creating the templates for the schools to use.
Okay. Mr. Chairman, did you have another round?
I have another couple of questions, but you can keep going.
Okay. Ms. Purdue, while I have you, I wanted to ask about how things were going in terms of the implementation of the Access to Emergency Medications bill. And whether or not things are on track for implementation this school year, upcoming school year, rather.
Yes, we are on track. We have drafted the plan. So the next steps include the rulemaking process. We have started the process for some of the procurements that need to be in place. And once the funding is available at the beginning of the school year, at the fiscal year, we should be able to move ahead with those procurements.
Okay. And in terms of, I think you had a back and forth with the chairman around the Universal Student Health Form. What's the progress on making this electronic? We've been talking about it for a number of years.
It's complicated. Yeah, it's complicated. We are still working with Children's and Cerner on the electronic process of submission of those forms. And we're exploring some additional options with DCPS as well that could make submission of those forms from parents a little bit easier. So that's where we are with that.
All right. We can get into that more offline. Mr. Chairman, I don't have any further questions at this time.
Thank you, Councilmember. A couple of questions. Ms. Purdue, you gave some statistics a minute ago, maybe it was 5 minutes ago. How many, you mentioned transports, and there was another statistic you gave.
There were 61 EMS transports this past 4 years. Yes.
That sounds pretty serious. And there was another statistic you gave. Was it the total number of seizures or?
There were 699 students. Oh, 0 fatalities. Is that what you're referring to?
No.
699 students who are on a record as having a seizure disorder.
Okay. One other question. I'm a teacher at a DC school and it's the first week of school. How do I know if there's a student with a diagnosed seizure disorder in my classroom?
Right now, there might be some gaps. However, there is a process between the health suite as well as the AOM trained staff and the school administration to have the records of the action plan or IHP, individual health plan, or medication plans on file. That communication would happen at the school level or with the health suite. But since we don't have all of those forms for all of the students, there could be some gaps.
I was going to say, so there are not those forms or plans for all students. What were you going to say?
Right, for all students with
Sure.
seizure.
I was just gonna add that the health suite staff, nurse managers, and principals have a start of the year meeting each year where they review cases that require information sharing. And so that is a part of that early start of year meeting.
These health suites are not fully staffed all the time in all of the schools. Am I correct?
They are now I'll say they are now staffed with at least one staff person. And there are schools that are supposed to have and will have additional staff people depending on the circumstances of that school. And we're about 85% complete with that staffing coverage.
I didn't completely follow that. I think we have required or tried to require that every school have a nurse. Not every school has a nurse. There's this cluster model that there's a nurse available for every cluster of schools, but not every cluster actually has a nurse. And then there are, I forget a nurse technician.
Right, so all of the health suites have health suite personnel.
But it might only be one in a school.
Right,
One health
there might be
personnel
one, right.
who might be absent that day.
Right, but we have additional coverage, and then there are also schools that will have additional staffing that is full-time that we're working towards, and that's where it's
Working towards.
yes.
Okay, well, but there's a gap there. And then my question was, I'm a teacher at a DC school. It's the first week of school. How do I know if there's a student with a diagnosed seizure disorder in my classroom? There might also be a student for whom there has not been a diagnosis. We got testimony of that, didn't we?
Correct.
Okay. And so how do I, as a teacher, recognize that without any training?
That's where we support the training.
Okay. Give me just a second.
I think it's important to note too, in addition to what Ms. Purdue just raised, that we encourage parents to bring in the health forms. When the parents bring in the health forms, they have a meeting at the start of the school year, health suite and principals. If there are students that flag as needing some special attention or some information that is need to know, principals then make sure that that information translates and gets to the appropriate instructional staff.
Yes, that sounds very neat and orderly. I think there was some testimony that some people have seizures for the first time.
Yes.
And so the only way that that gets caught is somebody is trained to recognize it.
Yeah, so that's where the undesignated epinephrine doses that are in every school would come into play.
I have no further questions. Councilmember Henderson, last shot for you.
Thank you, Mr. Chairman. I just want to clarify a couple of things. So, because I know some of the statistics that Ms. Purdue provided are certainly alarming, but I also want to be sure that we have on the record the protocol as well. Because so Ms. Purdue, I know, for instance, with EpiPens, for when an undesignated EpiPen is deployed at a school or an EpiPen that is prescribed, is it not protocol that EMS still has to be called?
It is.
Okay, so is that the case for seizures as well?
Not necessarily.
Not necessarily. Okay. So in terms of the 61 EMS transports for seizures, do you happen to know how many of those were known cases, like students who had known seizures versus those who this was the first time that they had had one?
We can certainly look into that and provide that information as a follow-up. I don't know if FEMS has anything else to add to that, but we can provide that.
Okay. I think that would be helpful. And I recognize too, right, we all want students to be safe and to have all of the things. I am, there's a part of me that is cautioned by, I hear like the school leaders or the teachers in my ear saying, they want to be as prepared as possible. And yet we want them to do all of the things. We want them to be experts in academics, experts in learning, and then also, be the nurse and the social worker and this and that and this and that and that. And so I'm trying to be cautious of mission creep in terms of all the things that we are asking. Even if we were to incorporate some type of comprehensive first aid or medical training for an educator at the beginning of the year, what does liability look like, Ms. Purdue? Let's say we train all of the teachers and professionals, and then some in the emergency, a teacher didn't catch it or something happened, and then there was a situation. Is that person now legally liable for not acting even though they were trained?
I mean, that's where Good Samaritan laws come in, and also distinguishing between, let's say, broader training we do for all school staff versus what health suite staff or AOM trained staff are expected to do. Which is also why we're trying to distinguish between what education might be provided to students, right, versus those AOM trained staff.
Okay. Yep. Like I said before, I think that this is going to require some additional conversations to make sure we get this right. And I think even one of the other witnesses sort of saying to ensure that it's implemented with fidelity. This isn't something that we're going to be able to do at the start of school year 24-25. There's just not time. And so I just sort of want to acknowledge that to roll something like this out is going to take a little bit of time. Not that you would know this, but since we've been having these sort of ongoing conversations about other bills, what's a suspected FIS for something like this?
Is that for me?
Yeah.
I would have to get back to you on that. As far as the AOM training and the, training expectations for health suite staff, and even the action plans, I think that would potentially be rolled into some of our existing funds that we have for enhancements we're making this school year. But I'm not I would have to go back and look at some of the other components of the bill.
Okay. Even without legislation, in terms of the seizure action plans, that's something we could be requesting from families now, right? If you know that your child has a known seizure disorder, please provide that information to the school in the same manner that you would do for other things, correct? Even if it's not required.
Correct, we could, and even Epilepsy Foundation has templates for seizure action plans that could be adopted, so.
Is that possible? Is that something that we can incorporate as we gear up in the summer? We are in the summer. As we gear up over the next couple of weeks around making sure that folks, one, are turning in their UHS form, but also that they're getting their updated childhood immunizations to remind folks. Because I mean, you know, just in last year when we were talking about this, the number of students who have asthma versus the number of asthma action plans we have on file, we're not even over 50%. So it feels to me as though we need to be doing more in terms of informing families how important this information is. To the chairman's point, if we don't have the form, or if a family doesn't disclose, how is the teacher or anyone in the building for that matter supposed to know?
Right, I think requiring the forms will be helpful. Right now, they're not a requirement. And so therefore, when we don't have all of them, we are where we are. But requiring them will certainly be helpful.
Okay. All right. Thank you, Mr. Chairman. That's all the questions I have.
Thank you, Councilmember. Thank you, each of you, for your testimony. That's going to conclude this hearing. I want to thank all of the witnesses and remind folks, if anyone wants to supplement their statements, provide additional information, or anyone who has not testified and wishes to comment, you have 2 weeks to do so. Record will close at 5 p.m. on Wednesday, July 24th. The time is 5:06 p.m. and this hearing is adjourned.